Thank you very much for this very kind introduction, and thanks the organizers for inviting me. So it's a great pleasure to be here in this very nice auditorium. And so I was asked to give you a lecture about the stem cell transplantation in myelofibrosis or in MPNs in general, which becomes more and more important. But it's very difficult to give you a clear recommendation now. Therefore, my primary intention is to get you more familiar with this procedure, because even in the physician, even not every physician knows what's really going on and why are we doing this and what are the complications. So I will give you some background, because I know if there's an indication for transplantation, the patient are always very scared about the complication, about the risk. And I know from our experience with our patients, if we train the patient, if the patient knows what's going on, then at least the scare or the fear goes a bit down and they become more optimistic. So I was asked to give you the lecture about the MPN transplantation. You have heard this several times. So we have the so-called BCR-ABL positives. This is the chronic myeloid leukemia, which we will exclude today. Then we have this BCR-ABL negative MPNs. You can see you mainly heard about PV, ET, and myelofibrosis. There are also some rare myeloproliferative neoplasia, mastocytosis, so there are different mastocytosis. There's also a group of so-called MPN unclassifiable and also some rare chronic neutrophilic leukemia, for instance. So in general, all this disease can be cured by allogenic stem cell transplantation, but there is not always a clear indication for doing this. And I will mainly focus on these major myeloproliferative neoplasias is PV, ET, and myelofibrosis. And you have heard this as well, and you know it. So we have the ET and P vera, we have the myelofibrosis, we have patient who can transform to myelofibrosis after ET and P vera, then it's called post-ET, post-PV myelofibrosis. But we also have very rare, but it can happen, that ET and P vera go straight to so-called blast phases, or is also called transformed acute myeloid leukemia. And also the myelofibrosis, so the primary myelofibrosis or post-ET or post-PV myelofibrosis can also transform to acute leukemia. So what we should avoid is actually to get in this blast phase, because this blast phase, it can be cured by allogenic stem cell transplantation, but the risk is quite high. So I will mainly focus now on here myelofibrosis, either primary or post-ET. So and you heard this very nicely from Claire, that when we treat patients with MPN, what is our treatment goal? So what do we want to achieve? This is always very important. And for instance, in ET, you have heard the major intention is to prevent thrombosis. In PV, it's actually the same. We want to prevent thrombosis, but we want to reduce also symptoms, as you nicely heard from Ruben this morning. In myelofibrosis, we want also reduce the symptoms such as this weakness, splenomegaly, weight loss, but also because in this patient, the life expectancy is much lower than in ET and P vera. In some patients, we want also prolong survival and even want to cure these patients. So in general, before I go too much into detail, in general, so currently in 2017 or 2016, there is for P vera no indication for stem cell transplantation. There's also no indication for stem cell transplantation in patients with ET. The only exception is if one of these diseases is going to transform into so-called acute leukemia, which we call blast crisis. Then it becomes a clear indication, and there's actually no doubt that the patient is in good condition and has a proper donor. In myelofibrosis, it's a bit different, and probably there is an indication, not for every patient with myelofibrosis, because this depending more on the status of the disease, but also on donor availability and also on age. And I will give you some examples how we should select patients for transplant, or when we should offer transplant, and when we should wait for the transplant, and in the next slides. So what can we achieve by allogenic stem cell transplantation in myelofibrosis patients? So we can achieve a complete hematological remission, including molecular remission. These actually, they can resolution of the splenomegaly, resolution of constitutional symptoms, regression of the bone marrow fibrosis, complete regression of bone marrow fibrosis, and long-term survival and this is actually if we have a complete remission, no fibrosis, no symptoms, then we call it cure of the disease. This is actually the intention. If you do a stem cell transplantation, the main goal is to cure these patients. However, not every patient can be cured by stem cell transplantation. There are also some risk. The major risk of treatment failure is actually, it's not therapy-related mortality, it's relapse. So we should be taking into account, if we take all patients with myelofibrosis who received a stem cell transplantation worldwide, about 20 to 25% of the patient will experience relapse in the next years. So not everybody is cured. The other risk factor is so-called treatment-related morbidity and mortality. So and this is depending on age, this is depending on constitution, on the donor. So between 5, 15, in some centers 20% can have so-called non-relapsed mortality. So this is an example how the bone marrow fibrosis is rapidly resolved, and this is a very interesting biological observation. So it doesn't take many years that the fibrosis is resolved. So quite rapidly, so this is before transplantation, the majority have this MF grade 3, that means you have this severe fibrosis, you have this osteosclerosis, and only 3 months after transplantation you can see the fibrosis is completely resolved. There's only some residual osteosclerosis, and we investigated this in several series, and this is quite interesting how rapid the fibrosis is resolved if you use stem cell transplantation. So what actually is a stem cell transplantation? So you know probably from your experience, and you heard in the media, and you know renal transplantation, heart transplantation, liver transplantation. So everybody can imagine what happens. So you take the organ out and you put a healthy organ in. So this can be imagined by everybody. So stem cell transplantation means actually we're dealing with blood. But blood itself, it's also an organ, but the organ is not restricted to a certain place. It's all where bone marrow is. So bone marrow is actually in all the ribs, in the sternum, in the spine, even in the skulls, in the pelvis. You can find always bone marrow. So the bone marrow is actually the source of our blood. And the blood, what you have in the circulation, so when you investigate your platelets, your hemoglobin, or your white blood counts, the physician is always taking some blood from the veins. However, this blood is only the product of the bone marrow. And in the bone marrow, every day, billions of these cells are built up, and only the good cells are going out into the blood. And if there is some wrong in the peripheral blood, actually physicians should go to the bone marrow to look what's really going on. And within the bone marrow, we have so-called stem cells, so hematopoietic stem cells. And these cells account for only less than 1% of the cells in the bone marrow. But these so-called stem cells, they have the capacity to go in different, we call it lineage directions. So they can do by several steps, and this is a simplified cartoon, by several steps, so-called megakaryocytes and then platelets. They can cause erythroblasts and then red blood cells. They can cause myeloid progenitor cells and then granulocytes or monocytes. They can cause lymphoid cells and then cause lymphocytes. And actually the disease, most of the myeloproliferative disorders, and especially myelofibrosis, is a disease of a very early stem cell. So the stem cell is actually, one of the stem cells is not okay, so is ill. So it becomes quite obvious if you replace the wrong stem cell, the ill stem cells, by a healthy stem cells, you might get a normal blood count, a normal hematopoietic system. This is actually the underlying idea. The question now is how do we get these stem cells out, and how do we get the healthy stem cells in? So if you look to the literature, and you have heard this, so stem cell transplantation is actually distinguished between so-called autologous stem cell transplantation. That means you take your own stem cells, or allogenic stem cells when there is an HLA-compatible donor available. Autologous stem cell transplantation is actually nothing more than you give a very high dose of chemotherapy. By the chemotherapy, the hematopoietic system will completely destroyed, and then you replace it by your own stem cells, which are taken out before you use this high-dose chemotherapy. So that means autologous stem cell transplantation is only high-dose chemotherapy, and the stem cells are used to support this treatment. But the stem cells itself has no therapeutic effect. It's just supporting, like you get platelets or red blood cells, then you get stem cells. And these stem cells then can recover and complete the new hematopoietic systems. So in myelofibrosis, this is not working. So there were some investigations a couple of years ago, but this is not working. All patients relapse quite fast. So when we talk about allogenic stem cell transplantation, it's the same procedure, it's the same name, transplantation, but actually it's something completely different. And it's different because you transplanted the donor cells from a healthy donor, and within these stem cells, you also transplanted, and this we have to take into account, it's not only the blood cells. Within the hematopoietic system, it's also the complete immune system. So you are transplant also a new immune system. When we started the transplant 50, 60 years ago, this was not known. Everybody thought it's only the chemotherapy and we give stem cells from them healthy. But actually you transplant also a hematopoietic, lymphoid system, immune therapy, and it's mainly is the so-called T cells. The T cells are one of the immune system which is protecting the body from foreigns, for instance. So in other words, if you transplant a new system with a new hematopoietic cells, they can cause trouble. Because you can imagine if in your body would be a new hematopoietic system and a new immune system, the major intention of any immune system is actually to simplify it, to distinguish between what is mine and what is not mine. And everything what is not mine is danger, so should be avoided. So if you got now a new hematopoietic system, including a new immune system, which is not yours, because yours is depleted by the chemotherapy, and then there is something wrong. Because then the new cells, they believe it is not your own body, and they begin to attack. And this attacktion, we call it graft versus host disease. And this is mainly against skin, against gut, or liver, for instance. And we call this graft versus host disease because it's mainly the reason are these T cells. And in the beginning, when we had these complications, everybody thought, so we should avoid this complication. And this is feasible, so it's not, you can avoid this by manipulating the graft, by giving medication which suppresses graft versus host disease. And then everybody thought it was fine. But actually what happens is that a substantial number of patients relapsed with their disease. And the cause is because they have lost this graft versus myelofibrosis effect. Because the same T cells which are causing, or more or less the same T cells which are causing graft versus host disease, are also targeting the myelofibrosis cells, so I mean the malignant hematopoietic cells, because for the foreign immune system, these cells are also foreign, so they attack these cells. So this we call graft versus leukemia, or in this particular case, graft versus myelofibrosis effect. So in other words, the graft versus host disease can be dangerous, can be harmful. On the other hand, it's also useful because it's just the other side of the same coin of these so-called T cells, which are donor-derived. So actually, to have a very good transplantation, the optimal is to have a bit of this graft versus host disease, which is not harmful for the patient, to harness this graft versus myelofibrosis effect, which is very important to avoid later relapse. So if you understand this procedure, this is actually the basis of stem cell transplantation, allogenic stem cell transplantation. And so, but how should we decide? Because we have the risk of graft versus host disease, there's also the risk of infection, so we should select patient probably and to recommend the transplant. So we always have to balance, and this should be done in every patient, so it's an individual decision. So we have here the potential cure, which is the strength of the allotransplant, but we have, on the other hand, we have therapy-related morbidity and mortality. But also we have, on the other hand, so-called alternative options. The alternative options are not so much in your disease, actually, especially regarding prolonging of survival. So, but maybe we have here the JAK inhibitors, which are now in the market, and they can prolong survival as well. But we have also to consider other factors, not only disease-specific factors, also patient-specific factors. So we have to think, to be very realistic, so usually we have to see the patient, and when we should see, so what is the life expectancy of this patient without transplantation, roughly? Or what is the age of the patient, and does he have comorbidities? Does he have other problems, diabetes, renal insufficiency, cardiac failure, which also can harmful the transplant procedure? And are there alternative options? So when we use these so-called disease-specific factors, and you have heard this morning, is the so-called dynamic IPSS. So there are some risk factors which can be summarized in a so-called risk factor, and then we have low risk, intermediate 1, intermediate 2, and high risk. And if you transplant, and this is from a registry, if we transplant patient according their different risk in myelofibrosis, you can see the low-risk patient have a survival, or it's more or less, you can see the long follow-up of about 80%, intermediate 1 about 60, intermediate 2 also nearly 60, and high risk about 50%. Then you would say, okay, this sounds very good, because here we have 80%, here we have 60%, which is quite good. However, we should take also into account what happens without transplantation. And without transplantation, you can see the low-risk patient and intermediate, they have also a quite good overall survival. So the median survival is more than 10 years. For the intermediate, it's about 10 years. For low, it's more than 15 years. But you can see that intermediate 2, for instance, on high risk, you can see survival curve goes down. So there, the so-called median survival, that means when half of the patient are still alive, half of the patient have already died, is quite short. And therefore, just for the disease-specific, there is consensus, and there are also some retrospective studies suggesting that the recommendation for myelofibrosis patients with intermediate 2 and high risk is for going for stem cell transplantation, to check whether they are feasible for stem cell transplantation, whether there is a donor. While the recommendation in 2016 for intermediate 1 and low risk is actually to wait and to observe these patients. Maybe this will change when we have more data about the ruxolitinib and the long-term outcome of ruxolitinib. They are starting now some studies. So in Germany, we will do a comparison between ruxo and stem cell transplantation in patients. So we will see. But currently in 2016, it's for intermediate 2 and high risk. You should consider a stem cell transplantation. So what are the prerequisites for stem cell transplantation? If you need, of course, a donor. Without a donor, you cannot do a stem cell transplantation, not an allergenic stem cell transplantation. So we need, and we call it HLA-compatible donor, and this can be either an identical twin, which is optimal regarding the complications, because the immune system is 100% identical. But probably, as you have learned, the complications are very low, but the risk of relapse is very high, because it's pretty much the same, so therefore the risk of relapse is quite high. So usually we take this as a first choice, but it's very rare. It's only every 300 patients has a syngenic twin. So they are HLA-identical siblings, and more recently also so-called unrelated donors in a large registry. Just for you, how this is working, this is the so-called human leukocyte antigen system. So I simplified it. We look actually for 10 of these. Here is six of these HLA molecules. So every patient has 2 of these allele, and these can be the same, they can be different. So this is the father, this is the mother. And if both of them have children, you can see, let's see an example. This is the patient. You can see this allele is coming from the father here. The second one is coming from the mother. And all the other children, you can see it's only child number 3, which has by chance received the same HLA system like the patient with his child number 0 here. So this child would be an HLA identical sibling. So the chance of getting a sibling is if they are sisters or brothers is 1 to 4, so it's 25%. So because the families becomes smaller and smaller, and there are not so many brothers and sisters, at least in the Western countries, so there is now the system of so-called unrelated donors. And this is a quite interesting thing, because these are human beings, healthy human beings, who want to donate stem cells for ill patients, even if they don't know them. So they said, okay, I will donate my stem cells, my healthy stem cells, for somebody else in the world who is ill and who needs these stem cells. And meanwhile, there are more than 20 million volunteers in these registers, which can be asked to donate stem cells for a leukemic patient around the world. So for the so-called Caucasian, which is the race for the European and North American, the likelihood to find a volunteer is more than 80%, because most of the volunteers are also from the same race. For other ethnics like Black or African, it's more difficult to find a donor, because in this registry the majority are Caucasian. And therefore, this is from our European register. So the numbers of stem cell transplantation is steadily increasing. This is autologous, this is allergenic. Here you can see this is the unrelated. The unrelated is now more than 8,000 in Europe per year. This is the sibling transplantation. And even for those who don't have an unrelated donor and don't have a sibling donor, new options arise. So one is the cord blood, this is the blue one, which is going bit down. And more rising is new options. We call this haploidentical stem cell transplantation. This is a new method to use also sisters or parents or siblings which are only half matched in the HLA. However, there are differences in outcome. So the best donor still for myelofibrosis patient is the HLA identical sibling, followed by a completely matched unrelated donor. So when we know how do we get the stem cell out of this healthy donor or from your donor, and actually there are three possibilities. Either we take the stem cells out of the bone marrow, so I mentioned this is less than 1%, and then we call this bone marrow transplantation. We can take also the stem cells from the peripheral blood. You can see it's even less, so therefore these stem cells needs to be mobilized by specific medications, that the stem cells go into the blood and can be harvested. Then we call it peripheral blood stem cell transplantation. And altogether we call it stem cell transplantation. Maybe you heard bone marrow transplantation, stem cell transplantation. It's just depending where the source is of the stem cells. And we have also the cord blood options. So everybody from you know probably how painful the bone marrow punction is. So as painful is it also for the donor. So the donor has to do a complete anesthesia, and you can see that the bone marrow will harvest. And you need for a bone marrow transplantation, you need about 1.5 liter for 70 kilo. So this is quite painful for the donor, but the donor is willing to do this for the patients. So the other option which becomes more popular is using from peripheral blood. Therefore, the donor is not a patient, the donor received some GCSF stimulation, and after 4 days, the stem cells comes into the blood and can be harvested by so-called leukophoresis. And you can see there are 2 venous access, and the blood is going in this apheresis machine, and the stem cells were collected. The rest of the blood goes back to the donor, and you can see the volume is much lower, and you can see it looks like more yellow. It's because platelets are in, but the number of stem cells is still higher in these peripheral blood stem cells than it is in bone marrow, even if the volume is lower. So what is next to do for the patients? Because then we have now the stem cells and we have the indication for stem cell transplantation. So I mentioned before, if we would give the stem cells to the patient this way, he would reject it, because the immune system of the patient still is capable to reject the stem cells because it's not their own immune system. So what do we have to do? And this is for all patients, is we have to do a so-called conditioning before the stem cells were infused. And the conditioning regimen has actually 3 aims. One is to allow the engraftment of donor stem cells by forcing the immunosuppression in the patient. but we need also some anti-tumor efficacy to reduce the load of the malignant stem cells for myelofibrosis. And at least in the past, it was believed we need a myeloablation in the bone marrow, so we need space that the new stem cells will find their way to engraft and find a nice place to build up their own system. And in the past, it was believed that this can be achieved only by very high dose total body irradiation and very high dose of chemotherapy. And this was so toxic that stem cell transplantation was performed actually only for younger patients, so upper age that was 45 or 50 years. But then by especially mice, but also by dog experiments, it could be shown that, first of all, we don't need total body irradiation to make a complete immunosuppression. I showed you that the anti-tumor activity is mainly based on the T lymphocytes from the donor rather than from the chemotherapy. And also we don't need this myeloablation. So even if the patient has no old residual cells, the new cells can engraft as well. And since this is becoming obvious, it's now feasible to reduce the intensity of the conditioning. And this is called so-called mini transplantation or reduced intensity conditioning. But this allows to reduce the toxicity of the entire procedure, and this allows now to transplant also older patients. So currently 70 years of age is not a limited. It depends always more on the biological. So how is the constitution of the patient rather than the age. So and after this conditioning, which is still toxic and can induce hair loss, it can induce organ dysfunction, then the patient become a phase of aplasia. Then the old hematopoietic system is gone, the new has not been created. So about 14 days, these patients are in aplasia. That means they don't have any leukocytes, they need platelet support and also red blood cells. And usually this phase is about 14 days, and patient has to be in a strict isolation to avoid complications such as infectious problem. So after 14 days, then we see the first cells, leukocytes, and these leukocytes are then usually from the donor. This can be tested by genetic markers, and so the patient is about 4 weeks in. But then, as I mentioned before, this new system should create langsam build up. So it's like a small flower, I would say. So then you need to be careful about infection, to be careful about GVHD, to treat this, that the patient is not getting GVHD. But it's also very important because now you have this new immune system of the donor. And if the physician then can modulate this immune system, to get more GVL effect, more graft versus myelofibrosis if there is residual disease, avoid GVHD. So you have a platform where you really can work with. So this is really important, the so-called post-transplant period. And this is quite time-consuming, but actually in our department we have only the most experienced physician in this outpatient department, because this is very crucial for the success of the transplantation, so-called post-transplant period. So the last slide is actually just to highlight this is to avoid more, we should really do the transplant as a package. And therefore, if there is a patient who needs a transplant and there is a clear indication for transplantation, then we should prepare this patient properly for the transplant to avoid the complications. So we should not start here today, we should start very early in collaboration with the hematologist or the general practices. So we have several strategies today to improve the patient conditioning before he's going to transplant. For instance, we can reduce the spleen size by JAK inhibitors, as you have nicely heard. In some patients, very rarely, but you can remove the spleen as well, but this is no clear indication. You can improve the constitutional symptoms and the weight gain by JAK inhibitors. You can reduce the iron overload if this patient is heavily transfusion dependent by so-called chelation therapy. And you have time to define the optimal donor. And within the transplant, you should consider the optimal conditioning regimen according the patient's condition, so it's more an individualized approach rather than a one-size-fits-all. And then the so-called post-transplant strategies, this is more to avoid the relapse and to avoid the therapy-related mortality. So these patients should be monitored very closely. And you heard also at this meeting, there are a lot of molecular markers. So in myelofibrosis, for instance, with JAK2, with MIPL, and with calreticulin, you can target 90% of the patients. And you can develop with this molecular marker very sensitive marker which you can monitor in the blood. And if they are still positive, then you know there is still residual disease. Only if they are negative, then you are quite sure that there is no residual disease. And this molecular marker can guide you with your immune system, to reduce immunosuppression. And in some patients, we can give also additional T cells after the transplantation, the T cells just to get this graft versus myelofibrosis effect. And also the JAK inhibitors is also very interesting. They can prevent, or they are currently in clinical trials in severe graft versus host disease because they are quite immunosuppressive, so they are quite useful to treat graft versus host disease. So they can be used also, at least in clinical trials, either to prevent or treat graft versus host disease. So at the end, I would like to thank the members of my department, but also the European Leukemia Net, the members of this consensus, the EBMT, the German MPN group, and others which we are working with. So I hope I'm open for some questions. Thank you very much for your attention.